All right, welcome everyone. We better get underway. So my name's Nick Swar. I'm the Executive Dean of the Faculty and Chair of GoldNet Research Network. And it's great to see so many people here this evening. I've got about 15 things to do at once here, one of which is to click the slides. But obviously the evening's on opioid prescribing in primary care. We've got a range of speakers who I'll introduce as we go through. But I'd like to, I think, start with by acknowledging traditional custodians of the land on which we meet, the Kumbermeri people of the Yugambeh language group, and acknowledge Aboriginal as past, present and emerging, and thank them for their stewardship of country. So, yeah, so a little bit about GoldNet, and it's great to see so many people here tonight, but just in case you don't know or haven't formally joined the network, you're very welcome to. It's a practice-based research network, so it's trying to support research activity in the general practice and primary care practices. And we've now got over 150 members apparently, which is fantastic, including GPs, practice nurses, practice managers, allied health and researchers from both nationally and internationally. We've got 9 research projects that are active at the moment, and we've supported 11 projects over the history of the research network. We have 2 face-to-face events each year and 2 online journal clubs each year, and this is the first face-to-face event of the year. As you can see from the logos at the bottom, it's a collaborative group. GoldNet Research is a collaboration between Bond and in particular the Institute for Evidence-Based Healthcare with Griffith University and Wang. Kylie made it, well done. Gold Coast Primary Health Network and General Practice Gold Coast. And so all of those groups collaborate, and we've got a steering committee which has representatives from all those organisations where we sort of plan the activities of the research network. And as we get approaches from research groups who would like us to help support the research in terms of promoting it through the network, we consider those applications and size them up, I guess, on their value as a research project, on their practicality, you know, how much effort and involvement and expectation is there for practices, and we make recommendation out then whether or not the research will be supported by the network. So from time to time, people who are part of the network will get requests to take part, and at the end I'll give a bit of an update on what projects are active at the moment and some progress on some projects. So thanks everyone for your involvement in the research network, and I think research in primary care is a very important thing. So this topic came out of discussions actually at the steering committee. We're thinking about, you know, what are some of the topical issues facing primary care practitioners and people, you know, with chronic pain or sort of acute pain, but pain problems. We all see them in our practices. I think we all struggle from time to time about how best to respond. And so it seemed a very topical thing to cover, particularly as we saw those opioid deprescribing guidelines came out in the MJA a few months ago. So that seemed topical as well. And we've gathered together a range of people to present tonight, and then there'll be time at the end for a panel discussion and general questions and comment from the audience. And of course, I'm sure the presenters would be happy as we went along to have questions as well. So we have several presenters. The first is Dr. Caitlin Jones from University of Sydney, who's going to talk about the OPAL trial, opioids for acute spinal pain. Then we have Aili Langford from Monash University, who's going to talk deprescribing opioids in primary care. And then Joyce McSwan, who many of you might know from, who works with the Gold Coast PHN, is going to talk a practical approach to translating opioid guidelines into clinical practice. And by sheer luck, both Caitlin and Aili happened to be on the Gold Coast. Yeah. And even better, we didn't have to pay their flights. So fantastic to have you both here. And I'll invite Caitlin to come up first and talk about the OPAL trial. There we are.
Thank you very much.
Sorry. All right.
That's a good start.
Yeah.
Hello, thank you very much for having me. So I'm here to talk about the OPAL trial, which was a placebo-controlled trial of an opioid for acute back and neck pain. It was published a couple of months ago. That QR code will take you to the full publication, but I think it's maybe run out of its free access period. So feel free to email me and I can send you a copy of the full paper if you're interested. So low back and neck pain are incredibly common. They're two of the most burdensome conditions in terms of how much disability they cause and financial implications as well, with back pain having a point prevalence of about 8% and neck pain is about 4%. So that translates to over 577 million people around the world are experiencing back or neck pain at any one time. And of those who present for care, between 40 to 70% are prescribed an opioid, depending on the setting. In primary care, it's more like 40%, and in emergency departments, it's more like 70%. And this is in line with most clinical guidelines at the moment that do recommend that opioids can be considered for acute back and neck pain as a second or third line treatment when other less risky things have been tried and failed. However, the guidelines haven't been based on direct evidence because before the OPAL trial, there'd never been a placebo-controlled trial in this population. And in recent years, there's been calls from peak bodies around the world to reduce our use of opioids and to do that by identifying the conditions where the benefits that opioids offer don't outweigh the harms and to reduce or cease prescribing in those conditions. So back and neck pain clearly needed a trial being so common with such heavy prescription of opioids happening and no direct evidence to actually know, is it helping or is it harming? So hence the idea for the OPAL trial was conceived. We wanted to recruit people with acute, non-specific back and or neck pain who were just naturally presenting for care. They had to have at least moderate pain, and then they were randomized to up to 6 weeks of either an opioid or a placebo and followed up for a full 12 months. So everyone that joined our trial, we ended up recruiting 347 people. They all received guideline care, and we weren't too prescriptive about what that was. We just encouraged every prescriber to offer guideline care. And what was different between the groups was just the tablet that they took. So half of the people were randomized to take oxycodone 5 milligrams with naloxone 2.5 milligrams in a modified release formula, just because that's how it was available in Australia. The drug's called Tarjan. And we recommended they start on one tablet twice per day, and the prescribers could titrate as they saw fit. And the control group received identical placebos on the same regimen. We said to prescribe for a maximum of 6 weeks or until recovery, whichever came first. Our primary outcome was pain severity at the 6-week time point, but we took lots of other measures of pain as well. We took daily pain scores for the first 12 weeks, and we did the full brief pain inventory at weeks 2, 4, 6, 12, 26, and 52. And we took a range of other outcomes as well, all the things you'd expect: time to recovery, function, quality of life. And to just jump straight to the headline, so we found that opioids were not effective for acute back and neck pain. So those red arrows there are pointing to the primary time point, which is about 6 weeks, the opioid group in orange and the placebo group in gray below. And you can see that right from the first time point, there's this trend to the placebo group actually having lower pain scores. And if you're a numbers person, the between group difference at the primary time point was about 0.5 point out of 10, with the confidence interval including 1. And we typically say that 1 point out of 10 is potentially clinically meaningful, but that difference favored the placebo group. It wasn't statistically significant at the primary time point at week 6, but you can sort of see those lines separating over time. And right at the end, at the 12-month time point, that difference did tick over just to being statistically significant, where there was a benefit to being in the placebo group, where they had on average about half a point less pain compared to the opioid group. And that trend of results was continued through all our secondary outcomes as well. So for every outcome at every time point, there was either no difference or small differences, always favoring placebo. there wasn't a single time point or outcome where there was a benefit to being in the opioid group. And that last one on the table is particularly interesting to me, that at 12 months, there was 20% of people in the opioid group at risk of misuse compared to 10% in the placebo. And that was collected at 12 months after they'd had a short judicious course of opioids almost 12 months before. For adverse events, we found no difference between groups, which surprised me as well. About a third of everyone in the trial reported at least one adverse event. The people in the opioid group reported all the classic opioid-related adverse events, and the people in the placebo group reported a broad range of random things. So OPAL was the first large and long-term study looking at the efficacy of opioids in this population. And based on these findings, I think guidelines should be changed to no longer recommend opioids for acute non-specific back and neck pain. But the next question that obviously brings up is, what next? How do we actually implement that into practice and reduce opioid prescribing? And I'm sure everyone in this room is well aware of how complicated and difficult that is. Well, there's not necessarily great alternatives to offer people. A couple of discussion points I wanted to mention is we used a modified release formula, which most guidelines at the moment recommend using immediate release formulations, of course. In our defense, OPAL was designed before those guidelines came out. But the reason we chose it is just because it was available in Australia, formulated with naloxone, which we wanted to use because it would reduce the opioid-induced constipation, which we thought would help people be more compliant to the regimen by keeping them more comfortable, and also keep them blinded, because that was one of the major issues we had designing this trial, is how do you really blind an opioid trial? It's pretty hard to miss if you're on an opioid. But that formulation with naloxone did the trick. And when we tested blinding at the end of the treatment period, people weren't able to guess what group they were in. So my pharmacy colleagues tell me that the modified release formulation will have achieved the same blood concentration eventually if taken regularly after the first day or so. But of course, it means OPAL can't answer the question about immediate pain relief in the first couple of hours after they start taking it. But I know people I work with have another trial in the works that will answer that question in the near future. Another discussion point that's come up since publication is about our primary time point being 6 weeks, which does seem like a long time for an acute pain condition. And people are wondering, did we miss an effect? But like I said, we took daily pain scores for the first 12 weeks. And this graph is showing time to recovery. So we've got the opioid group is the red line, and the placebo group is the blue line. And there's really no pattern happening there. But if anything, in the first 14 days, there's a trend towards the placebo group recovering faster than the opioid group. So it's not likely that we did miss an effect prior to 6 weeks. And I just want to acknowledge all the people that funded the trial, the operations team that were the engine room, the investigators. Professor Christine Lynn is my supervisor. I was her very lucky PhD student, and she's really the brains and the brawn behind the OPAL trial. All our collaborators and the 157 doctors, 94 pharmacies, and 347 participants we worked with. And while I've got a microphone, I just want to say we're doing heaps more research with GPs as well. So if you're interested in getting involved, please do send me an email. My email's on the next slide. For example, we've got a trial about to start testing duloxetine for chronic sciatica. We've got a trial underway testing an oral corticosteroid for acute sciatica. So if that interests you at all to get involved, please do get in touch. And there's my email, and again, the QR code if you would like to read the whole paper. Thank you very much.
Time, so we've probably got time for a few questions.
Sure.
Yeah, Michael. Yeah.
Just wondering, was there any data on what dose of Tarjan was escalated? What was the top dose, or was it everyone on the 5?
So a couple of people were up titrated. I don't have figures off the top of my head, but a small proportion were titrated up to 10 milligrams twice a day. And I think there was one patient from memory that went higher than that, but most didn't. Also, it might be interesting to note that most people had come off the drug, either the opioid or the placebo, within about 2 weeks. Very few people actually stuck it out for the 6 weeks.
We would probably start with a higher dose. Yeah, if you were going to use something like that, you'd probably start with 10 and go up high. Yeah, so because normally the PBS gives you a 2-week pack of Targin, so you'd try 10 and then maybe go higher, go to 15 or 20. Yeah, so I just wonder whether the lack of an effect may have just been that they weren't taking enough. Yeah.
It's possible. So that dose came out of the Australian Medicine Prescribing Handbook, I think it's called, and all of our patients were opioid naive as well. So, but it's a good point that possibly maybe it wasn't strong enough. Doctors did have the option to increase it. That didn't seem to have much of an effect.
Thanks for the presentation, Caitlin. I'm just wondering, apart from biological intervention, whether there are any other intervention like psychosocial or physio involvement in the trial?
Yes, so there was no restriction of what the prescribers could also refer the patients to. So some had physiotherapy, some took other medicines as well. There was no difference between groups. So we asked people to report what else they did as well as taking the tablet, and it was about even across the groups. Yeah.
Thanks so much, Caitlin. That's fantastic. Now we'll move on. I should have said actually before we started, if people need the bathrooms, toilets, they go outdoor and down to the right, sort of past the atrium entrance, then you'll see the toilets down that way. So if they're needed. Next is Dr. Aili Langford from Monash University, who's going to talk to us about prescribing opioid analgesics in primary care.
Hello, everyone. Thank you so much for having me in sunny Gold Coast this evening. No, I was actually very disappointed with the weather when I landed from Melbourne this morning, but I've been told that it hasn't been all nice all week, so it wasn't me that brought the weather with me. I'm going to be talking a little bit about the opioid deprescribing guidelines that were mentioned earlier. So the opioid deprescribing guidelines were a project that was led by a team at the University of Sydney. And although my affiliation is currently Monash, the work that I'm going to be speaking about was conducted during my PhD in Sydney. So I think you'd all be very familiar in terms of the current opioid landscape in Australia. This data is from 2018, stating that we currently have the 6th highest opioid consumption globally. And of course, there's some quite significant harms associated with opioid use, including emergency department presentations, hospitalizations, and deaths. And I actually saw an article in the MJA just yesterday that has said opioid prescriptions have declined slightly since 2020, when the PBS restrictions in terms of the indications that the PBS covers have been implemented, but still the majority of opioids are prescribed in primary care by general practitioners, and much of that is for chronic non-cancer pain. So there's been a range of strategies to try and promote more judicious opioid use in Australia. Some of those strategies have come from the TGA in terms of those PBS indications. There's been the implementation of prescription drug monitoring programs across Australia. But one maybe infamous response that many people would be aware of is the CDC guidelines from the United States of America, which were first published in 2016, and then there was again an update in 2022. But one of the unintended consequences of the 2016 guidelines was that many people were abruptly cut off their opioids, and this led to an array of harms, demonstrated increases in rates of suicide, illicit opioid use, mental health crises. And so whilst these really well-intentioned guidelines tried to reduce harm, of course, there were unintended harms that resulted. And so the knowledge of this really fed into my research team's agenda to develop evidence-based guidelines to deprescribe opioid analgesics. And I know the word deprescribing is a contentious one. Some people don't like the term. But in terms of what our research agenda was, it was really about the safe and efficacious reduction or cessation of opioid therapies. And we largely focused on chronic non-cancer pain as the population of interest. So to develop this guideline, the first step was assembling a multidisciplinary guideline development group. And we had key stakeholders from across Australia representing general practitioners, pain specialists, addiction medicine specialists, pharmacists, nurses, physios, as well as people who have expertise with methodologies and some organisational representatives as well. We were working with NPS MedicineWise at the time. They no longer exist, but that team endeavoured to answer sort of three main key clinical questions, which really was, does opioid deprescribing result in net benefits or harms? And what are those potential benefits and harms? What is the best approach to actually go about doing this in terms of how to deprescribe? And finally, which interventions are most effective to facilitate this process? To answer these questions, there was a range of evidence syntheses, but we started off by qualitative stakeholder interviews with, firstly, healthcare professionals, and we've published each of these components of the overall guideline, and they're probably written quite smallly down the bottom. So if you have any questions about the individual components, again, happy to share links and things. But yes, the first one was with healthcare professionals, and we also did a qualitative study with people who take opioids for pain to understand a little bit more around the challenges of deprescribing. We conducted an overview of systematic reviews on different interventions for opioid deprescribing, as well as a range of other systematic reviews to answer our guideline questions. And then we used what's called an evidence to decision framework to contextualize these recommendations and really consider what factors may influence the implementability of these recommendations in practice. So you can maybe see from the slide, there's facets such as resources or feasibility that need to be considered when trying to convert evidence to practice. If I could give an example of one of our recommendations, we found quite strong evidence that multidisciplinary pain clinics or programs were the most effective intervention for actually reducing or ceasing opioids whilst allowing the patients to maintain pain and physical function. But in terms of these feasibility components, it's clear that people cannot access such services easily. There may be long wait times to be able to attend such a pain clinic, or if they are more private, there may be significant costs associated with these services that limit access as well. So based on this evidence to decision framework, we were able to rate the implementability of the different recommendations, and that led to the recommendation of conditional recommendations in some instances, rather than what's known as a strong recommendation, which I suppose can be more easily implemented by clinicians across the board. So once we generated our draft recommendations, we did send the guideline out for public consultation, and we received feedback from quite a large number of organisations in Australia. Many are listed on the screen, as well as a lot of state government health departments, and then a huge number of individuals as well provided their own personal feedback. And this allowed us to refine the guideline content and the recommendations. And ultimately, we came away with 11 recommendations. Some are what are called consensus recommendations rather than being informed directly by the evidence. And so if I could give an example of that, one of our consensus recommendations was actually against deprescribing when a patient has a limited life expectancy. And so for instance, there were no trials comparing continuation versus discontinuation of opioids towards the end of life, because there's likely ethical considerations in running that kind of trial. Yet the guideline development group felt it was really important to make recommendations about when it's not appropriate to deprescribe as well, to try and mitigate some of those potential unintended harms that were observed in the United States. Ultimately, our guideline was approved by the Australian National Health and Medical Research Council, and this really reflects the robust methodological processes that were followed to develop this guideline. You may be familiar with some other resources that provide information about deprescribing opioids, but to my knowledge, this is the first guideline that has followed the stringent processes for development that we would expect from clinical practice guidelines in general. And we also received endorsement from some Australian organisations who thankfully also provided feedback during the process. Ultimately, our guideline was published in the Medical Journal of Australia not too long ago, and that is open access, so everyone should be able to access that online, and there's a QR code there if you would like to have a look imminently. But I'd just like to finish off by saying that this work is ongoing. We're very acutely aware that a guideline on its own is very unlikely to change practice. Dissemination and implementation efforts are definitely going to be required. And so our team is now thinking about what steps can we take to trial implementation of this guideline into practice. And I've been fortunate to have received a small grant through the Australian Association of Gerontology to look at developing some consumer resources specifically for older adults, and an investigator grant through the National Health and Medical Research Council, which I have just commenced, and looking to do more work in this space. So again, if anybody is interested in discussing future plans, I'd be very happy to chat further. And just a very large thank you to the huge number of people who contributed to this guideline. Hard to list everybody, but a big special thanks to my PhD supervisors from the University of Sydney. Thank you.
So again, I think we've got a few moments for questions. If there's questions for Aili.
I really take your point about sudden deprescribing, and especially in elderly patients. We had one patient that left a practice because they stopped all her opioids, and she was desperate because she was in so much pain, and she came to us, and we sort of had to sort of sort things out. But it really caused great distress for her doctors. I think were scared of the nudge letters that Medicare was sending at the time, because all the GPs got a letter saying, you know, you've got to cut down on prescribing opioids, and everyone got a bit scared and they stopped doing S8 scripts, and this lady just got cut clean. So it's a big problem.
Yes, I agree. I think it's incredibly complex, and I think that really hit home with me with some of these qualitative interviews when speaking to people about their own lived experience and going through this themselves. And I think that's why whenever we talk about this guideline, or even if you read the summary in MJ, I think there is a large focus on individualizing treatment. We don't have specific recommendations in terms of a one-size-fits-all approach to tapering. In fact, when you look at the evidence, the best trials in terms of being able to reduce people's doses and improve or maintain pain and function were ones where they didn't follow a stringent protocol of reduce by 5 to 10% every X, Y, and Z. It was ones that were adapted to meet the needs of the patient, which I think seems kind of intuitive, but yet clinicians, I think, also like this directive of this is the process to take, so follow it. So I think, yeah, individualizing treatment. And in terms of the scaring practitioners, I think that's something we heard from GPs and health practitioners more broadly as well, and really difficult because you want to almost incentivize people to work with the patient and kind of follow best practice rather than scare people into an ultimate outcome of reduced opioid use, which might be the goal, but as we said, might have other unintended harms.
Thanks, Aili. We'll have more time for questions when we get to the panel section. But I'll now hand over to our next speaker, Joyce McSwan. Joyce, as you might know, works with Gold Coast PHN in the Persistent Pain Program Clinical Director role, and also with Brisbane North PHN, and is president of the Australian Pain Society. So over to you, Joyce.
Thank you. Clicker, yep. Thanks. This is such a pet topic of mine. I love opioids, all in the good sense of the word. It's not an easy area, but it's a real joyful area, I feel, and we do need to reduce the fear of it. And one way I've been very privileged to do that is often with collaboration. And as Aili said, the MDT approach truly is wonderful. So tonight, what I'm trying to do is just bring a practical approach to how we do it in terms of non-specific cancer pain, so chronic pain or persistent pain, and how do we do it in a practical way. And I'll show you an example of what has one way of what has worked, which you may wish to approach it that way. I'm sure you all have your different permutations. My disclosures are there. And right, so I'm really a big wordsmith, and I find that words are really impactful for patients. They are easily fearful when a medication they've been taking for pain is suddenly threatened in any way. It's not just about the pain anymore. It's about their family, their ability to work, their livelihood, their mental health. So what I like to use the word of, and we've tried many of these words out with our patients and sort of evoke different emotions as we go, but I like the word rationalization. So rationalization is it, looks at it very individually. Deprescribing is there. So there's a couple of words for you: polypharmacy, reducing, withdrawing, harm, benefits, cost, safety, and actually making sense. When things make sense to patients, and we try and be quite simplistic about things, when things make sense to patients come to the decision themselves. They're actually really, really smart. Often we kind of feel like we're perhaps maybe the clinically smarter one, but to be really honest, much of my experience has come because of learning from the patients and how to solve these problems that has that behavior change. There's reconciliation, there's efficacy, there's quality, there's tapering, there's wean. So those words we sometimes use quite interchangeably, and they're very impactful when you're trying to do, evoke a behavior change in the patient, and not just evoke the change that's your change, it's to lead them into wanting that change themselves. And when they go, so what's next in this process? That's when you think, yeah, bingo, right? And it's a bit of there's a bit of theatrics there sometimes, right? You have to get into their mirroring sometimes, you have to talk their lingo sometimes, and building that rapport is incredibly important. So I follow a simple process, and I don't always stick to this process, but I find this really helpful. And it's quite simple in terms of finding out what matters to the patient, identifying the essential drug therapy. Does the patient take unnecessary drug therapy? Are therapeutic objectives being achieved? Is the patient at risk of adverse drug reactions or suffering from actual adverse drug reactions, or even know about potential ones? Is the drug therapy cost effective? And then obviously what is the patient willing and able to take in that drug therapy that's intended? So always patient-centered. So now we do sorry, it's a bit small, but one of the really important things is what I call risk propensity, meaning letting the patients be fully aware of the risks of what they're doing and helping them to understand and bringing them, I suppose, to your understanding level of what is risky in what they're taking. So, for example, we tell our patients that, look, there are some serious harms, and usually from a third person approach rather than at you or about you, because sometimes that distance is helpful just purely for information. Accidental overdose can happen, death can happen, hospitalization, there's an increased risk of that, unconsciousness, respiratory failure. And so we then give them numbers. I find numbers really useful because it gives them something to kind of anchor on rather than you're taking too much. It's that very too personal. When we sort of give them the dosing and go, look, it'd be great if it was under this dose, but however, the reason why I'm saying that, there's actually an increased risk, and the risk is you're at 1.5 times greater to get these issues, or 9 times higher as you get. And so it's very evidence-based figures. So they start to go, oh, okay, you're in the red zone. I really want to bring you to the green zone. How do we get to the green zone? Do you want to be in the green zone? Of course I want to be in the green zone. Great. Okay, let's think about whether we can get there and how to get there. So immediately I think, they get information that's meaningful. So, and the risks are likely to happen to develop in 80% of patients on long-term opioids. So we deal with patients who are on chronic long-term use that we're trying to bring to a safer place. So rationalization is like this, like we can all draw Van Gogh, maybe not. But when you start to rationalize it and put the colors in, you start to bring out the artistry of medicine. And that's what we try and work with our patients on. And then it's very individual. And that's really important for them to see that you're individualizing it for them, and for their lives and what it means to them. That's really important. So medication rationalization is complex, has to be, there's careful judgment required, but there's also this thing called unconscious bias. These are unconscious biases in every one of us that's very automatic. So sometimes it's having to step back a little bit, and it's a practice that's why I say it's artistry. It's a practice for clinicians to sort of step back from our own fears on our own unconscious bias and sort of go, how am I judging this case? So that balanced approach then can come in a lot more when we elevate from that. And it is a practice art. It's not you don't get out of school one day and just go, oh, I think I know how to solve this and I have no conscious bias. I think sometimes you gain that along the way with your own, hits and knocks of practice. So then what we look at obviously is that risk and versus benefit. So look, it's easier said with some pictures. Making sense of pain. So when we actually look at a patient, I'm going to get quite practical now with the case. When we look at a patient, especially with their pain, making sense of pain, we have to identify the key contributors to their pain. What is it? Is it nociceptive from osteoarthritis? Is it neuropathic? Is it nociplastic, or what we call sensitization? Is there a degree of central, maybe peripheral sensitization? So it's very important for our history taking to really identify these. So I do circles because I literally draw circles. I literally start to artistically show their pain on a piece of paper. So as they're describing, oh, my back, and it's, and when I stand up, this happens. And when I start to walk, that, that intense sciatica comes on. So I literally, as they're talking to me, I'm going, yeah, it's muscular. Yeah, we've got a bit of neuropathic impingement happening. Yep. And how does that make you feel? Oh, I'm so down about it. I can't sleep. And yep, that's a circle. So they then see that their pain really has many contributing factors. Otherwise, if we don't do that, we found it's very much that MRI, that CT, my L5, S1, that focus is so narrow. And I often say to them, that's like a massive camera. In that very one moment when you get in the machine and we do a little selfie of your back, that's it. How's that going to tell me what it does to your life? So they then start to go, contributing factors. Right, there's so many other causes of my pain. Do you see where I'm going with this? So when you build that story and that narrative, you build rapport and all of that. And then you go, well, what are you taking? Let's have a look. So you then start to do cross-matching. Right, Tarjan, all right, maybe it fits there. Oh, okay, yes, you've had some of those injections. That fit there. How long did it last? Oh, right, well, your body broke it down pretty quickly. That's understandable. Oh, it wasn't supposed to last for 6 months? Well, no, because your body type obviously breaks it down a bit faster. It's got to get out somehow. So it's that narrative that they need to understand as well. And you're taking that, right? That's looking after that mental. So we try and really put in place what's meaningful for them, so they can start to see their drug therapy being allocated and then be unallocated. So the rest of it that you take, the Panadine Forte that you buy, or the Neuromol, whatever, the stuff that's on the side, you go, what do they do? Oh, I don't know, not too much. Just give it a go. So you start to sort of build another little list on the side. So they then start to see what's in and what's out. And that's really important for what I call medication rationalization. So we start to build that story. So how much does the what's out stuff cost you? Well, I don't know, a fair bit. My bill at the pharmacy is a fair bit. So then you then put it back to them. Well, what do you want to do about that? Well, I don't know. Stop it, maybe give it a go stopping it. Well, if it's not working, why not? Doesn't mean it's going to go away. It can come back. And that's one of the things people sort of sometimes feel. They're like, it's going to go away. I'm never going to see it again. No, we're just trying. It's all right. It's there. You know where to get it from. We're just going to try because you allocated that maybe it's not in the picture. That's foundational, because I find from there the patient starts to get it in terms of, so why do I stop some of these that don't mean anything to me? How do I sort out? And often it's that assessment of, what's been going on in other comorbidities over 12 months, perhaps. And then looking at their health priorities and so on as well. So this sort of starts to become more the sprinkle on the cake as you can get further from there. So let's do it in a case like Sam. This is one of my cases. His name, of course, wasn't Sam. 65-year-old man, 160 centimeters, 70 kilos. In 210, he had an MVA, no fractures, concussion, and complained of neck pain at the time. So 213, there was depression, anxiety. 215, lower back pain from fall in his house while he was doing gardening. 216, lower back pain, complaining of severe tension. And then 2022, osteoarthritis, bilateral knee pain. So he was a commercial cleaner for 20 years, but he stopped work in 2016 and he was doing a bit of Uber and then he became a taxi driving, but now he's stopped. So behind the background, there's depression, anxiety, largely from the fact that his life had changed so dramatically from being a commercial cleaner. He was an owner of quite a large commercial cleaning firm. And obviously he had some normal, his biochemistry was normal. So he presented in ED quite frequently. In fact, there were 6 presentations in about the 2-month period that prior to me seeing him. And that was due to extreme pain. So Sam was very nervous when he came in. He appeared to, put a bit of a brave face on, very softly spoken man. You could see his gait had very much adapted. His stature had changed, and he was at the time complaining of back pain, about 8 out of 10. Tension in his muscles, localized in his L5S1 region, and as he does things, he would say became worse. There was a lot of localized allodynia in that peripheral zone, which basically limits how he can sit for. He was sort of going from site to site. You could see his sitting capacity was about 10 minutes. Walking capacity was about the same, with that antalgic gait. And he says that when he sort of goes uphill, it starts to really pull. He actually lies down way too much because lying actually helps with his pain. But he's got to kind of be like the rotisserie, he used to call it. And there was everything was fine, no red flags. There was no radiculopathy. And he was a bit apathetic, and he complained of being really tired and very fatigued. Insomnia at night. So then it was a really vicious cycle, couldn't sleep. Again, more rotisserie at night. So I was not keen to see Allied Health at the time because he had poor experience with the physio. They gave him too much exercise, he says, and it was he just couldn't cope. And he actually complained also of peripheral edema, which is quite sort of out there. So when we looked at his drug therapy and applied the rules of the rationalization practice, he was on amlodipine, he was on oxycodone 20 SR, which he'd started since the fall at home in 2015. So been on it for a while. Pantoprazole, he was on pregabalin as well. Again, started around 216, but couldn't remember, so just kept taking it. Duloxetine was 90 at night, and he started in 218 after he stopped driving his taxi, so he had really quite down times. Diazepam, and again, when he couldn't sleep or when his back spasms became worse. Paracetamol on the side adjunctively, ibuprofen he would buy over the counter, and then tramadol IR as well, as an alternative to paracetamol and codeine. So he had other interventions. He had a facet joint injection, nerve blocks, and they're all a bit marginal effect. And really, he just didn't want any more interventions. So his priority, this is really important, where you kind of having to find out where is your cut through, where's your buy-in. Sleep better, improve fatigue, reduce pain, back tension, ability to sit and walk for longer, and then he'd like to go back to driving taxis again or do some volunteer work. So as we drew the picture, we kind of basically displayed it all out a bit like this so that he could see all the contributing factors. And then as like the example I showed, we start to allocate where the meds could have been in, and then where it kind of was out, where it didn't allocate. So that way he could see perhaps where we could start to go the obvious. I mean, this man really didn't have, he had peripheral sensitization. He didn't have a neuropathic complaint. His complaint was certainly not that. But then when you get desperate in pain, like patients get started on all kinds of things, sometimes just let's try. And then the history has it that it was since 2016 and he was still compliant, but it didn't do very much. And he was so tired from it. So that was the obvious. And when he saw that, he's like, yeah, I never thought that did anything. So I was like, okay, would you like to start there? Could we try? So we went on a reduction dose and there was absolutely it wasn't a strikeout, let's stop it completely either. It was a gradual reduction. So you can see that, of course, we would all like to sort of head towards that blue box up the top, but rather than getting the jugular and ripping it out, it was very much just, it had served a purpose and was still serving a purpose. So to build that rapport, we looked at something that was definitely unallocated. So the pre-GAB was the one that we started to work on. And then looking at his side effects, peripheral edema, fatigue, insomnia. So the fatigue really was helped largely by the pregabalin reduction. So that was very, very useful, or in a first instance where he felt like he could do better. So to cut a long story short, as we kind of started to allocate and reallocate and make sense of his medicines, we started to get more and more involvement. Now, this was probably a good 4 months process. So this wasn't overnight. But with the collaboration of his wonderful GP, we managed to start to edge towards all kinds of things. So we changed the duloxetine to the morning dose so he wasn't, as alert at night. We monitored his testosterone because of long-term use of the opioids, reduced the pregabalin, and then basically worked towards cessation. We reduced the diazepam, and we actually trialed the orphanadrine instead, which was actually very helpful for the tight skeletal muscles. And it's only symptomatic, but at least it wasn't, reducing something for nothing. So they gave him a little crutch while we then helped him to get into confidence of, seeing a physio again. So orphanadrine was replacing diaz, and then we started some non-pharmaco things, teaching him how to use long continuous heat therapy, which I know, Kristen, Lynn and Ma and all them done some amazing work with. We love continuous heat therapy. It's got an incredibly awesome science that helps with the inflammation pathway and pain reduction pathway. And then we educated him about what physios can do, but not the scary type ones, he would call it. So it was teaching him, there's such things as lubricating your nerves, how to moisturize them. He's like, oh, and they don't hurt if you moisturize them. So it was teaching neural glides, basically. And that was very well adopted by him. He had a flare plan. So he didn't have a flare plan, he'll panic and then he'd up his opioids. So having a musculoskeletal specific flare plan, it's a hard one, was very useful. And then gradually getting the MDT team around him. And really was only the physio that was the major MDT that participated in this and gradually built that support up again. So you can see a case like that, it was coming in from the outside in, being quite meaningful. Actually, the peripheral edema we found out came from the amlodipine, so we changed that to lecanidine, and that helped a lot, and that was carrying a bit of the weight for that. Anyway, the long of the short was his testosterone was actually very low. So don't underestimate the power of opioids for testosterone reduction. And that was the fatigue and the apathy and working so hard with the physio before and just not being able to get that cut through that he needed. Vitamin D was also very low. He was quite indoors all the time. So again, you can see more modifications. And the low testosterone gave us a really good opportunity to talk about what was the causation. And he was having wifey issues. And that was like, oh, I think we found the culprit. And he didn't know about that. So he was really motivated. And I think by that time, he was almost going, please, what's next? This is going so well. He was begging. In fact, he was a bit gung-ho and actually did his own cessation. And I said, no, that's not allowed. We cannot do that. Well, so that kind of pulling him back was probably good for rapport as well. Anyway, the long or the short of it, after a while, was we started to, if you just cast your eye on 6 months later, we basically started to cut down on the oxycodone. When I do opioid reduction, I actually tend to like to do it 3 times a day. If used with Targin, I find that going down in 5s is a little less scary than a whole drop of, 5 each side or a whole drop of 10. I always say, look, that 5, it's not going to tickle your toenails. It's fine. You've got other things supporting you. So let's just work it down. So it can go to 3 times and then twice and then sometimes 3 times. Good thing with cutting down with Targin sometimes is it gets down to is it Targin or OxyContin, one of them. They go down to the 2.5. The pointy end of the stick doesn't become too scary for them. That last 5 drop can be a bit, sounds like it's just 5, but it's just that last one to let go. I have found for some people. So as you can see, he's busy with so many other medication rationalized opportunities now here. He was not even looking at his opioids. He was just asking for, hurry up, when is the next week coming? Opioid reduction withdrawals was quite low. Now, as you can see, lots of red marks across his changes, so quite phenomenal after 10 months. And you can see it took 10 months. It wasn't tomorrow. It wasn't, it wasn't that quick, but a year on later, his life changed so much. He could sleep better. He was less fatigued. He understood what was causing and contributing to his pain. He now could sit for 30 minutes, was walking for 20 minutes. Actually, the 20 minutes was actually sometimes a few times a week. And he had started going back to driving, but he also, more than anything, meaningfully wanted to get back to helping with his with the grandparents' reading time at school, because he could sit for the 30 minutes. That was his motivator. If I can sit for 30 to read the stories, I'm getting somewhere. So to tie it into the meaning, very quickly before I end, we also had to explain to him what withdrawals meant. Patients, I find, actually really quite like to understand withdrawal. Some of them feel like they're being punished. Some of them feel like they deserve to be punished. Some of them feel like, it's because they were, bad and took all these opioids for so long. It's a very biological process. And simply, it's a noradrenergic process. So I call it your factory needs to reboot. That's what happens. Your noradrenergic factory needs to reboot, and it can take a week or 2. It's normal. It's good to see you are rebooting. However, let's not make it so uncomfortable for you in the meantime. So clonidine, that's why clonidine and drugs like that do help and work. So as you can see here, just a quick pharmacology, the normal production of noradrenaline there is fine and opioid receptors are free. But then when you go to B, where an opioid sits on that receptor, the mu receptor, what it does is it can actually basically interrupt this converting enzyme situation, whereby you can get that interruption of the enzyme production. So you get an abnormally low, a drop in production of the noradrenaline. So people get acutely drowsy. If you're a virgin to opioids, you're like, whoa, that hit me. And that's because of the noradrenaline dropping. Now, after chronic use, what happens is it adapts. Our body just adapts. So that's why people are out there driving with, Targin, no problems, not drowsy. But then when you withdraw it straight away and reduce it, you get this excessive noradrenergic presence. And so you get the heebie-jeebies, basically. So that process is normal. It's biological. We need to support that. And sometimes withdrawals gradually or tapering gives it time to reboot. So I say it's your noradrenergic rebooting system. It's working really well. I'm pleased to see that. However, we might need to help you to just, give you some comfort symptomatically while we let it reboot. So patients love that explanation. They get comforted by it. It's a biological process. You didn't do anything wrong. You weren't fishy about your opioids. It would happen to me too. So they're the symptoms that we get. And just very lastly, there is this area of interest that I think is growing. And while we talk about addiction, there is this, it's a very complex area. And I bring it just to your attention, where long-term opioid users can be, I suppose, classified in this complex persistence opioid dependence. And this is where we have to case by case adjust and see whether this neuroadaptive process that's been due to long-term exposure of opioids, if we can for some of these people, or should for some of these people, go down to zero at all of opioids. Sometimes not, sometimes yes. In this Sam's case, he did reach zero. We monitored that he didn't relapse. We monitored he had continuously, other supports on the side. He was fine, but there was no guarantees. And we had to just watch that and work alongside with them. So thank you. Sorry, a bit longer than the others, but had a lot to say there. Thanks for listening.
What we might do, I think, is move straight into the panel session now and invite Caitlin, Aili, and Joyce all to kind of come up. We'll just bring a chair with us, and then we can have some more discussion. Excellent. We'll try to use the microphone.
I'll do the
Oh, we've got a roving mic as well. Thanks, Sally. So a lot to think about there, Joyce, and I guess starting off with Joyce's presentation, and maybe there's people in the audience that have preferred patients or worked with you with some of these cases. I guess what struck me about that was the time span is not short. It's quite an intensive process, and quite a process which patients need to be willing to go on the journey with you. I guess perhaps we have comments from the audience. So did that sort of Joyce's presentation sort of remind you of patients that you look after or situations that you've had? And if so, would you like to kind of comment and share with that? We've got, yeah.
Thanks, Joyce. That was a great presentation. I'd just like to say everything Joyce said. I mean, you're on a journey with the patient and you don't always get to zero. And you've got to take those patients with you. And some of them don't want to go. Some, like Sam, it's pretty easy, and others it's really, really hard. But, I know, Joyce, one of our concerns is that the guidelines are brilliant. That's wonderful. I've got them now, but I do read them when they come out. Oh, yes, it's lovely. But in the real world, when you've got people with a lot else going on, it does actually take time. And I'm finding so many of the younger doctors just, I don't do opioids. I just don't do them. And so as patients, doctors retire or leave the area, there's very, very desperate patients out there. And I wish all those younger doctors could hear what Joyce says, but they're all sitting at home going, well, I don't prescribe opiates, so I don't need to come this because I don't have that one. And I don't know how we get to make people realise that we do need everyone involved.
Yeah, Ingrid, I can't thank you enough, honestly, for helping us out so many times over and over. But we can't clone Ingrid. I wish I could. The true elephant in the room is almost maybe at the moment, depending on the season, but I would say in sometimes every second week, we have a forced withdrawal situation on our hands. And I mean, hot off the SMS list to our triage about, you need to find me a doctor. I have 3 days to find somebody, and I've had a phone call from reception to say that, I don't want to come, I can't come back. My doctor's not going to take me on. Now, this is no criticism to doctors. I know there's a lot of prejudice, and that's why our service, so grateful for PHN. We're here to support the doctors, not just the GPs. I know as a prescriber, it's very different, and often I get that, but you're not prescribing, Joyce. And that is true, but prescribing is not so scary either, because the laws and the Q script now and all those, if you keep your record keeping well, it's and apply medication rationalization principles, it's very doable, and it shouldn't be scary. And the best way to not be worried about it is to be MDT'd. We're just so lucky in the Gold Coast that we've got this program that can really help to support GPs on it. But still, in a program here, every fortnight, we get a forced withdrawal situation with the patient who's actually new coming into our program usually, or in our program, and then kind of, for whatever reason, no matter how hard we've worked, still, exposed to that. So it's a bit of a dire situation, and there can be repercussions too on the other side. Don't think that forced withdrawals doesn't come under an APRA watch. The pendulum has swung the other side before, whereby particularly if the patient has a mental health risk factor, and should they harm themselves and result in suicide, you've got another thing on your hands as well, and it is reportable. So again, not scaring that part, but it's not easy. But the easiest part I can say is to buddy up and to work together and work with a buddy colleague. That's something practical. Get with a buddy medic doctor and go, hey, will you back me up? Will I back you up? Let's look at each other's cases. Let's rationalize. If we're okay with that 20 BD right now, we're okay. Sign off, sweet, And I think Ingrid's done that for many of our doctors over time. But again, we can't just rely on one doctor on the Gold Coast. Like, we can learn together, we can work together. Those patients, while the journey's long, as you say, Nick, it's really possible. I've not ever had a not possible opioid case where they won't agree to reduce, especially when you educate them well and they kind of can see where your heart's from and what your intention is, which is, let's get you to the green zone. Nobody wants to sit in the red zone. Nobody, they don't want to be porcelain on the inside, and you got to tell them the truth of what it does and other options. So anyway, sorry, very long answers. Just cut me short, but I've got a lot of tips.
Any other comments on Michael? Yeah. Roving mic is on its way.
Thanks, Joyce. You know this talk is about opioids, but I think Lyrica is pregabalin's a much bigger problem potentially, and they've had a lot of issues, I think, coming out of the UK with suicides and serious harm. So Keith, you got any comments on that?
Yeah, absolutely. And that is certainly one to watch as well. What we have found is, while the focus was on opioids, and then it shifted to pregab as well, right? And sometimes the high doses are euphoric. So then they feel really good, I think there has been some evidence and trials to show that it's been used for anxiety as well. But the weight gain from it, man, that's significant. And that sort of the drowsiness that does bring as well. Look, the science of pregabalin really is now for truly neuropathic pain, not neurosensitization, not peripheral sensitization, not central sensitization. It really is only going to work for the GABA gates and the sodium channel exchange. Really, that's all it does. The rest is secondary really gain or side effects. So when I say neuropathic pain, what does that mean? I mean injury to a nerve or the degradation of a nerve. So like, for example, diabetes, peripheral neuropathy, where there is actually changes in that nerve. You've done a nerve conduction and you're like, yes, there's a nerve, or there's a severance or a injury. We don't tend to find that it's beneficial because of the side effects and because of the dose escalation, a potential when it's not neuropathic. In the heydays, we're also excited, right? When pregabalin came in the market, like, something else for pain. Quick, let's everybody be on it, because surely it does something. And yeah, we've understood more about the drug now and the harms. And you're right. I think if we talk to our AODS colleagues, I think that's one. I don't know, Ingrid, if you've got any accounts of pregabalin in your space of, but in the AOD space, are there?
But it's not a huge problem, to be honest. I've got one patient, one guy who was humongous from it, but yeah, it's not a massive problem that we're seeing in my little practice.
Yeah. And I think that's why that example is like the allocation of the drug does it really have a role? Are we talking about truly low nerve injury here? Is there a real neuropathic component that justifies its use? If it doesn't, and sometimes patients will go, I don't know, I've been on it for so long, I can't even tell you. So then we can trial edging down and go, did it make any difference? Nope. Okay, we'll go down a bit more. Did it make any difference? And for the weight gain, especially when we talk about pain, we reduce some of that load, weight gain, peripheral edema potentially. You get some gains already by reducing that. So I do agree with you, definitely, very much so, yeah.
Okay. I just one comment on the record. I saw a patient who the neurosurgeons had put on it from Gold Coast Hospital because he had sciatica and muscle wasting. So yes, it fitted, but it just made him feel awful. Unfortunately, he stopped it very quickly because it was just a really bad choice, I thought, for this guy. So it was interesting, but I think they were desperate to try something. So yeah, interesting. I had a question actually. If I could jump in here on well, I think it was your presentation, Caitlin. One of your outcome measure was at risk of opioid at risk outcome. I think you mentioned. So yeah, yes. What was that, and how did you measure that?
So that was risk of opioid misuse, not actual opioid misuse. And we measured that with a questionnaire that asks questions like, have you, gone to more than one doctor to get your prescription filled? Have you borrowed medicine from a friend? So yeah, sort of behavioral questions that then gives you like a numerical score and of how at risk of misusing that person is.
Yeah, I was interested that was what, double the rate, 20% versus 10% after a very short course of opioids in previously opioid naive. Now, causality you always have to be careful with, don't you, whether that's cause and effect, but that's a striking difference and is food for thought about whether to prescribe in acute pain or not if we're setting people up for risk of opioid misuse in the long term. I guess one of the other things that came up for me is medicinal cannabis, and I'm sure there's people in the room wondering about that. Where does that fit into the picture? A lot of people are taking it. A lot of doctors are prescribing it. Who wants to start?
I have one
Okay. Yep.
small comment, just to say that in the guideline evidence synthesis process, we did look at cannabinoids as one of the interventions to potentially deprescribe opioids. And I do think at the point that we were doing these evidence syntheses, it might have been a little bit early compared to the current state of affairs, because often when I talk about deprescribing, people ask me about transitioning to cannabinoids, but we found not effective in terms of deprescribing. I think largely for cessation, it didn't really happen. It was that often people were on both medications when it was trying to be used to dose reduce opioids.
Yeah, so we've watched this space close and well. You can imagine it's almost a daily conversation from my role locally, obviously in the pains program, right through to nationally in, Australian Pain Society. There's different viewpoints. It is for pain. It is one of the ones that in the SASB application process, it is the highest indication of application of medicinal cannabis as we speak. So there's different indications, right? There's anxiety, insomnia, blah, blah. And pain is like almost like 90% of the indication. Now that's interesting because the evidence doesn't say so. So where does it meet? Why is the question, right? And we've seen the changes in spikes when there was those letters that went out, where, you kind of see these pulse trends that suddenly these last few years or months is this whoop increase in the decoy route, really. So does the evidence measure up? Actually, not really for what we know at the moment. Doesn't mean research will change that. It may do. For neuropathic pain, I think there's a lean towards some evidence around that, but certainly for fibromyalgia, so that's more your central dysfunctional type of sensitization pain, no. For nociceptive pain, no. In terms of CBD THC, there's some evidence, small evidence to say that THC might have some very direct sort of nociceptive effects. But as you can imagine, this is a complex plant. It's full of amazing terpenes, and it's a very complex plant. Pharmacologically, we're so used to working one molecule, one target site. Sweet, right? But medicinal cannabis, that's why we need our expert prescribers who do this all day in and out and really start to really know their species types, because you almost have to be like a botanist, really. The really good ones are botanists eventually, because they know the multi-site. You just got one target site. it can be pros and cons, and I'm no authority on MC, but what I'm certainly seeing in the pain space for our patients is there's some curiosity. I haven't seen major opioid reduction because they've added in a medicinal cannabis. Often if they have a THC, they can't drive, so then that reduces their functional component. It might have had secondary benefits like reduction in anxiety, maybe sleep, but not directly on the pain itself. So it's quite interesting. It's a moving feast. And I think it's just being aware of it. It remains remains unapproved in Australia. So you as a practitioner holds the risks of that. We hope to learn together on it. I suppose it's not going away. It's going to be here to stay, but knowing judiciously, it's very expensive. Patients in our cohort can't often afford that. Some are reverting back to Nimbin because it's actually cheaper. True. And so, yeah, it's a very interesting one to watch. But in our setting, we've sort of seen it as a secondary add-on, but often not compliantly because purely they've got to eat. And it's just not affordable to continue, especially with the prescription version. Like they want to do it right, but it's very expensive. Yeah, that's one of the.
Wanted to pick up on comments made by Caitlin about the short-acting and long-acting opioids, because I've got a couple of patients on reasonable doses of oxycodone. And one of them had major orthopedic leg problems in her childhood, which deformed her leg big time. And one day when she was waddling into me to the surgery, I suddenly realised that we could probably do a lot better for her. And I referred her off to the orthopaedics at the Gold Coast Hospital, who've spent the last couple of years redoing hip replacements and knee replacements and lengthening her leg. And she's actually had a fall and refractured because it was such extensive orthopedic. Anyway, the point I was trying to make, and waffling on a bit, is that she needs the short-acting form of the drug for pain relief in order to do the physiotherapy exercises. They're so very important to build the muscles that are totally atrophied away because her leg was deformed for so long. And she's now got a leg that's the same length as the other one, and she can actually walk almost normally with a crutch. But she's still got a long way to go, and the physio exercises are so critically important, and she needs that pain relief to do them. And that oxycodone is just that short-acting oxycodone is such an important drug. And the long-acting one just doesn't cut the mustard. It just doesn't work like the short-acting one does. So I just really interested in further study about short-acting versus long-acting, because I've had two major patients with major orthopedics, and they both managed to break their legs again. Which sort of stopped me reducing the doses and re-escalating and stuff. But anyway, but I'm just saying it's important to listen to the patient, because they'll tell you.
Yeah. So I mean, I think that the theory is that with the regular dosing of the long acting, that you'd end up with an around the clock effect. But I would also be interested in another study, kind of replicating OPAL, but maybe using a short acting instead to see if that is any different, because that's some feedback we've had since publication. And yeah, I'm interested too.
Jane, just in a case like that, sometimes to avoid the dose escalation, and I appreciate what you're saying about that, because we get some of those cases with our bariatric patients too, where they cannot break down the MR very well, and they literally goes in, it comes out, and they're like, didn't work, right? So there's the surface area reduction, therefore it affects the bioavailability and the breakdown. So we have actually had to sometimes resort to the short acting and make up our own long acting, so to speak, right? So what we have found, because the dose escalation can sometimes, for some genetic types, go a bit faster than other genetic types. And that's where the drug choice can come in. So we have found, and it's pharmacologically backed, you can rotate to other short actings to keep the doses, you know, kind of as low as what's needed. So actually, no, it's not made anymore, is it? Shame. There's been some taken off the market, consequence of the Wendy issues some time back. So that's actually a trickle effect from some of the changes with pharma legislation. However, I know costly, but tapentadol IR is often a nice little break from the oxycodone or oxynorm if you need to for that interim period. Morphine short-acting options are fairly limited at the moment. We used to have Savrodol, but that's slowly going. I would hesitate on anything liquid, but tablets wise, I think we do tend to short-acting, go to the Palexia IR as an alternative for some people. But again, it's whether they can tolerate that or not. Yeah, the side effects on that one. Yeah. I think there's a comment at the back. Yeah, I think that's a bit forgotten, isn't it? The old little Temgesic there. That is an option. It's 0.2. I think we fear it a bit because that's buprenorphine, 0.2 milligrams. We fear a bit because the bup name, we're like, oh, isn't that used in the AOD space? So let's not touch that one. I think that's a partial agonist. And that I find pharmacologically just, you know, kind of one of those red herrings that you probably hear about and then go, yep, not interested. But it's for an opioid and pharmacological nerd like me, it sits also on what we call the kappa receptor site. And kappa receptor site has a role in being anti-hyperalgesic. So that's helpful from the viewpoint of reducing that, but you're not going to take a lot of buprenorphine. That's why it's been quite effective in Norspan drugs like that. You find that that's got a slower effect in hyperalgesia build up and tolerance effect. So there's it sits on another receptor site, not just mu, but kappa, which is another opioid type of receptor site, which has a little bit of that benefit. So if you want to read up on that, just look up kappa and hyperalgesia and you'll sort of get that pharmacology from there. But yeah, so Temgesic could be an option just as a break. It's not to say that she doesn't come back to the oxy, but just as a break so that their sensitivity builds up again potentially, and then the dose doesn't escalate. We found rotations really, really beneficial for patients. Yeah.
If they're on a long-acting safe what's the potential interaction between would it still be effective activity of Temgesic to have them on an if you were getting them off an IR put them on Temgesic on a swim next?
If there's a need for you can mix it up like that so that you're not wearing out the same receptor site, so to speak. You know, if there's if she is on a baseline of oxy SR, then she doesn't have to go to an oxy IR. She could potentially do a Temgesic as a short acting. Yes, you can be clever like that. Yes, for sure, that's an option. Don't be scared to rotate. Is that right?
Because it's partial question, we could potentially displace a bit of the oxy, I think.
Oh, I don't think so at that dose. Yeah, it's quite dose related. Yeah. Am I right? Pharmacologically, Uni of Sydney, Monash. I think it's dose specific from my understanding. You would. Yeah, the 0.2 is quite a low dose. It is can be very effective. I've got a patient who's got gut problems and bioavailability is so poor. Like there's no point putting in tablets in there because the sublingual is quite useful from that viewpoint. So thinking about formulations, you know, how you access the route is really useful from that viewpoint. If you're hammering the gut with the oral doses and you're like, man, we're not getting gut through, then maybe think around other modalities, whether it's you know, topicals or sublingual. I tend to avoid the liquids. I think it's too risky for usage and measuring doses. Patients go, I do a swig, and then I go, oh, don't want to hear about that. But it does happen when you give them the liberty of the bottle. Yeah, so just some thoughts there for you.
Pain is sufficiently controlled on the short term. We're down to 3 times a day now. It still suggests swapping around.
No, not if it's not escalating. Yeah, if your dose is stable. No. I'm just saying, yeah, no. Just saying that if it was in a situation where it was getting, yeah, then there's no need. Don't rock the boat if there's no need to rock the boat. Yeah, absolutely.
Well, thank you. This is for Aili. To de-prescribe, we need to understand the reasons for prescribing. What are some of the broader reasons for prescribing?
So I think perhaps if we think about the first recommendation that our guideline made, it was really about initiating or implementing a plan for deprescribing at the point of initiation. And so I think I can't really speak to all the different reasons for prescribing. I guess there's evidence to say that a lot is post-surgically and then transitions from short-term to long-term use. But I think also from more of our qualitative studies, it's that prescribers and maybe patients feel like they don't have many other options when it comes to pain management. So I can imagine if someone is coming in to the clinic describing pain and saying, I need something to manage this, that all prescribers are going to want to be able to provide something for that patient. And I think the feedback that we get from GPs, and I'm a pharmacist myself working with GPs, is that you're expected to make decisions based on 15-minute consultations. And perhaps there isn't that time to go through that really robust process that Joyce was describing in terms of rationalizing these medications, and maybe providing a script is the easy, more straightforward option. I don't want to generalize, but I imagine that could be a reason for the initiation of prescribing, and also possibly just an overestimation in terms of the potential benefits of these medications. I think a lot of people were incredibly surprised by the findings of the OPAL trial, for instance, and quite critical perhaps of the findings and trying to find reasons why it was incorrect. And maybe that's because we do just have this kind of assumption that, of course, these drugs are effective, because why else would they be prescribed and why else would everyone want to continue using them? So I think, to wrap up, a huge number of different reasons, probably both biological, sociological, system level in terms of resources and priorities and time constraints. And so I think that's why maybe if they are being prescribed and there may be good reason for it, thinking about what is that duration? Is there a plan for cessation or continuation or monitoring when they are prescribed?
All right. Well, I'd really like to thank all our presenters, and we have a wonderfully valuable certificate to give each of you. I know you'll treasure it always. Joyce and Aili and Caitlin. So thank you. And I just thank everyone. Thanks very much for that. And I'll just kind of finish up with a few, where's the clicker? Oh, thanks. Thanks, everyone. Few closing remarks. It's been a really interesting presentation, and it's great to hear the research and the practicalities kind of woven together. And I feel like I have to go back to pharmacology at university now too, because I must say the kappa receptor had slipped my mind somewhere, but I'm sure it's all flooding back. So where to, in terms of upcoming events for the research network, we have our online journal club. So you don't have to leave the comfort of your own home to come to this journal club. You can be sitting, eating your dinner or whatever you're doing at the time. And we're doing the next one in collaboration with the University of Queensland Practice-Based Research Network. And we're doing it on the topic of the benefits and harms of drug treatment for type 2 diabetes. There was a systematic review published in the British Medical Journal, and Loay goes through the study with us and helps us to understand the quality of the review and how the review was done and why they reached the conclusions they did. I'm chairing it, and we'll start off with a brief case discussion. And Catherine Wallace will be co-chair from UQ. Jeff Sperling from UQ General Practice is going to make comment. He mentioned this review in GPs Down Under, which alerted me to it. And he said it really changed his use of medicines for type 2 diabetes. So I was interested to see that. And we have Dr. Anish Menon, who's an endocrinologist from University of Queensland, a diabetologist, to give a specialist view as in a endocrinologist view, a diabetologist view on the evidence. So that'll be fun. And it's only ever an hour. We try to keep it to time. So that's coming up on whatever date it says there. 21st of May, 6 to 7 p.m. Just very briefly on sort of projects. Thanks for those who are involved in the Activating Primary Care COPD Patients with Multimorbidity study. Going quite well, 29 practices across the country involved. Thanks, Joyce. And we've had 221 patients in that study. So that's really pleasing, given that it's been a challenge to get recruitment. It's not easy, but going well, and really appreciate the support from people in this room who've been involved in that study. And I know it's at least 2 practices here involved in that research project. Another one that's happening, GPs use of non-drug interventions in primary care, this is a project from Institute for Evidence-Based Healthcare. And as you might know, people at the Institute are very involved in the RACGP Handbook of Non-Drug Interventions and trying to understand barriers and enablers for using non-drug interventions in general practice and trying to make them easier to use. And that's an interview study, either face-to-face or virtually with GPs. Another one, this one is from Griffith University, co-designing a vaping cessation program for young adults aged 18 to 24 years. You can see the QR code here. If anyone is interested, please scan that. Key stakeholders who may involve in the care of young adults, such as GPs, psychiatrists, psychologists, etc. And exploring ideas about helping young people to stop vaping. And of course, with the changes to vaping regulation that have come in fairly recently, the ban on disposable vapes, which are starting to have some influence. One of my patients who works in a vape shop told me people were coming in and buying $2,000 worth of vapes ahead of that ban, stocking up. Some of them stocking up for resale, I'm sure, as well. And a hot debate in Parliament. I think the legislation, Minister Butler just put it to Parliament last week, the legislation to move this regulation on. So it's a very topical project, that one. And another one that's just recently come to the steering committee, evaluating the feasibility of a digital program for secondary prevention of stroke. This is from Monash University. And they're trying to look to get 8 to 10 GPs across Australia to participate in a 1-hour focus group. I can't remember if there's some sort of recompense for that, Aili. I think there is. But there's something. Yeah. Anyway, so interested in that, there's a QR code on that one. So if you're not a member of the PBRN and would like to be, there's the code. Gosh, we've got a lot of QR codes tonight, haven't we? It's QR setting. There's the scan, and you can easily register. Then you get on the email list to be told about all of the journal clubs and the face-to-face events, and of course hear about research projects which the network is helping to support. Any closing comments, Aili, before we wind up, or from the audience? Aili and Amanda have done all the hard work on organising tonight, so thank you so much for that, as usual. Always brilliantly organised and runs very smoothly, and makes my life so easy. And it's 2 minutes past 8, so we better call it a night. So thanks everyone for your attendance.